Ladies and gentlemen, I'm presenting to you some brief notes outline on anorexia nervosa. I'm Dr. Prosper Tettey Doe in the United Kingdom. The eating disorder, anorexia nervosa is an eating disorder, and from the ICS-10 and DSM-4 classification, its BMI, body mass index of less than 17.5, self-induced weight loss, and self-imposed low weight threshold, and intense fear of gaining weight or becoming fat, and absence of 3 consecutive menstrual cycles in a female. What are the clinical features of anorexia nervosa? These are layered baggy clothing, increased arousal, restlessness and anxiety, low mood, reduced sleep, dread of fatness, body image distortion, strict dietary rules, preoccupation with food and weight, food hoarding, body checking, obsessional and compulsive symptoms related to food and cleaning. What are the physical examination findings in anorexia nervosa? They include low weight, BMI of less than 17.5, lanugo hair on the body, thinning of hair on the head, cold, poorly perfused peripheries, skin breakdown, poor healing, bradycardia, that's slow pulse, hypotension, low blood pressure, and muscle weakness. And the physical review and examination in the musculoskeletal system calculate the BMI in single layered clothing. BMI of less than 15 is severe weight loss, and BMI of less than 13.5 is critical weight loss. There's short stature, and this may be pathological fracture associated with osteoporosis, and also stunted growth if onset is prepubertal. Proximal myopathy. Observe the use of the arms when standing up from the squatting position. Dermatological findings are dry skin and Russell sign. The dorsal finger calluses caused by injury whilst inducing vomiting are the Russell sign. Physical review. The dental findings are loss of enamel, tooth decay, abscesses due to vomiting acidic or sugary food, excessive bruising or brushing, correction. Cardiovascular system findings, bradycardia, hypotension, postural hypotension, mitral valve prolapse, collapse due to dehydration causing hypovolemia, acute arrhythmia due to prolonged QTc interval and electrolyte abnormality. Gastrointestinal physical review findings, esophagitis, gastric tears, delayed gastric emptying, peptic ulcers, gastric dilatation, constipation, paralytic ileus, IBS, irritable bowel syndrome, and rectal prolapse. The central nervous findings on review include confusion or fits or coma due to low glucose and due to electrolyte imbalance. There are cognitive deficits, example, attention deficit, concentration, memory, visuospatial analysis, new learning, judgment, and problem solving. What are the investigations one would request as a clinician? These include hematology, starvation indicated by normocytic anemia, reduced white cell count, reduced platelets, ESR to exclude organic causes, urea and creatinine low in starvation, and raised indicating dehydration or renal impairment. Hypokalemia associated with purging. Hyponatremia due to excessive water intake to reduce hunger. Rehydration after chronic dehydration. Low magnesium associated with potassium depletion and refeeding syndrome. Phosphate low due to refeeding syndrome during active weight gain. Low phosphate due to binging at low weight, and high phosphate due to vomiting. Bicarbonates, alkalosis associated with purging and hypokalemia. Liver enzymes are raised in starvation. Protein, poor prognosis if the albumin is low. Amylase is raised with vomiting, and creatinine kinase is raised with excessive exercise in starvation, and thyroid function tests consider differential diagnosis. ECG, baseline ECG, consider effect of medication on QT interval and monitor with low weight, purging, and electrolytes imbalance. Bone density scan, screen for osteoporosis and monitor every 2 years. Pelvic ultrasound scan, polycystic ovaries associated with bulimia nervosa. Multifollicular ovaries common during weight restoration. Assessments, physical assessments, physical examination including mouth, muscle strength, hydration, syncope, look for syncope, and proximal myopathy, as well as hypoglycemia. Psychiatric assessment include mental state, risk assessment, risk of suicide, personal history, family history, smoking, alcohol, and drug use. Investigations include the baseline bloods, which are mentioned as on the slide. And in prescribing thiamine 200 mg daily for 2 weeks, multivitamin, sanatogen, and vitamin B co-strong. Paracetamol maximum 2 grams daily, Diarrhyte as required, and mebeverine as required. During refeeding, physical health monitoring is important in the first 2 weeks of admission, with slow refeeding using low fiber, energy dense, and phosphate-rich diet. Consider refeeding syndrome when there is hypophosphatemia, hypokalemia, hypomagnesemia, edema, heart failure, and gastric dilation. Medical interventions, assisted feeding, meal support by skilled nurses can reduce the need of the following: nasogastric feeding with short-term feeding to facilitate weight gain for medical stability. Aim is to improve the patient's cognitive function to promote readiness for engagement in treatment. Percutaneous endoscopic gastrostomy (PEG) feeding inserted into the stomach for a longer-term feeding solution. Ongoing care includes review the mental state, physical state, medication weekly, review capacity and consent, good liaison with nursing team before making decisions, serial blood tests including use an ease and phosphate twice weekly for first 2 weeks, then weekly till risk is stabilized, then fortnightly, then monthly, then stop when stable. Bone scan, dentist review, pelvic ultrasound in females, edema, medical complications. Nursing care and observations. Consider closer observations if concerns regarding over-exercise or vomiting. Also, observations may be required in the bathroom and toilets. Thank you for your attention on Anorexia Nervosa notes. I wish you all the best in your careers.